are believed to be more sensitive to any sensory stimuli, and thus they're actually more prone to pain and to consequences of pain. And that's because like some of the inhibitory pain pathways have not developed in preterm infants. And that's why you see that infants have more generalized responses to pain than older children, whereas older children have localized responses, but the generalized response actually suggests that it's a more extensive pain response, so a higher sensitivity to pain. But because newborns can't report their pain like verbally, other than by crying, then they're very dependent on us to recognize, assess, and manage it. So there was a big study in Canada looking at the number of painful procedures in neonates in the NICU, and it's 14 painful procedures per day. And there could be long-term and short-term consequences for this. But it's really under-recognized, undertreated, and not really evaluated or managed well. And this is despite there being really a vast body of literature that supports ways to effectively assess and manage pain. So it used to be you could say like, well, we don't know how to manage this, or we don't know how to assess this, but that's really not the case anymore. Like there's good literature out there. So sometimes in the NICU, they think about two different types of pain. Acute procedural pain, so there's lots of short bouts of pain, and then chronic or persisting pain, which they say is lasting more than 3 months. I don't think that's a very useful definition. I would say persisting pain is anything, beyond the 1 hour of a procedure. So I kind of dispute that, but that's the definitions they use. So a few more facts. Like we said, the neural pathways in premature and term infants are sufficiently developed for pain to be experienced and felt. If a procedure is considered painful for adults, then it should also be considered painful for babies, even if they're premature. So you would never intubate an adult without sedation or analgesia. You would never do a lumbar puncture without some local anesthetic. So the same needs to be applied to babies because they actually, like we said, are experiencing more pain. And there's some big studies that show that if the pain is better managed in neonatal units, then there's less clinical complications and mortality. So the recommendations are to use a combination of environmental factors, behavioral meaning non-pharmacological, and pharmacological interventions to prevent, reduce, or eliminate neonatal pain. And just a reminder that sedation does not provide pain relief, and it may mask an infant's pain response. So when I say sedation, I mean paralytics, muscle paralyzing agents, or just things like benzodiazepines or anesthetics. They provide no analgesia. But they make the child not move, so you don't know they're in pain. So that's why even during surgery, you cannot just provide anesthetic, or during a procedure, you need to also provide analgesia. And for preterm infants especially, a lack of behavioral response, such as not crying, not moving, does not indicate a lack of pain. And we'll see that from the pain scales, that the response to pain in premature infants is decreased movement. And it's important that we engage parents in pain management as part of a family-centered approach to care. So we have a lot of responsibilities as care providers to assess, prevent, and manage pain. And the recommendation is that all clinical units that care for newborns should have guidelines and protocols for the management of neonatal pain. So we have those. If you want more of those, I can share like our neonatal pain protocols and guidelines that we use. Some basic things is to avoid unnecessary noxious stimuli. So this means avoid unnecessary noise, unnecessary light, unnecessary temperature changes for the baby. Have them be in the incubator, it'd be a quiet, calm, temperature regulated environment. And then to minimize the number of procedures that need to be done. And then the pain really has to be treated. Our responsibility is to initiate a combination of pharmacological and non-pharmacological interventions. And there's lots of nice non-pharmacological interventions, but in general, they're not appropriate without a combination with pharmacological. So that's mainly what the recommendations suggest. So we have some neonatal pain assessment tools that help us measure pain in infants. So I think I gave you a lot of detail on these, but we don't have to discuss it in detail. Do you know which one they're using right now? Are they using any standardized pain assessment tool for acute pain in the NICU?
They don't use anything, Megan. They are not, they realize that there is pain, but they don't make any effort to measure it.
Okay.
But they know that NIPS and PIP and NPAS, they know that they exist.
Okay.
So yeah.
Okay. So, I mean, it depends on how you want to go forward in terms of kind of getting them to choose one, because sometimes even if they don't use it consistently, getting people together in the unit, like the unit manager, the nurse leader, the physician leader, and having them discuss the tools and choose one as the official one or two, is an awareness building exercise. And then having some kind of plan where you train all the nurses in it, again, builds the nurses' awareness of how to better assess pain, even if it doesn't lead to 100% compliance with pain assessments later. But that's not always the goal. The goal for some of this training is maybe just build awareness, get them to be better at assessing pain. Like they might know that crying is a sign of pain, but teach them more about how to assess the baby's face, the movements, any physiological measures. Those are some thoughts I have. And I'm happy to do that when I come too, if you want to kind of leverage my visit.
Yeah, we should work on it, definitely.
So we use the NIPS and the PIPs. But the basic thing I did when I looked at all the research for all these scales, they're all very similar. I would say the NIPS and PIPs have probably the best research to back them up, but still it's not like tons and tons of babies. It's not thousands of patients. It's hundreds at the most. But I find these are fairly good and my nurses will use them. But like I said, even here, we don't use it every single shift. They're not always scoring the pain. But if they're like, I don't know if the baby's in pain, or if I think the patient's in pain, then I'm going to score and then show them the score and get them to see that the child is in pain. So I like the PIPs because the first thing you decide is the gestational age, and you score that. And then that helps you because it adjusts it for the gestational age. And then you score this behavioral state: awake, meaning eyes open, facial movements; awake, quiet, eyes open, no facial movements; active sleep, eyes closed, facial movements; quiet sleep, eyes closed, no facial movements. So each of these things you score, and then it's very easy. There's only 5 other things to score: heart rate, oxygen saturation, the brow bulge. So you teach them that, this is a sign of pain in babies; eye squeeze, same thing; and the nasolabial furrow. So all of that you just score, and then you get a score. So they can do it fairly quickly. Like it says, observe the infant for 30 seconds. Now, the one issue might be the oxygen saturation. I see that you probably aren't always measuring that. But this is the samples that they use. These are the patients they use to develop this scale, with like an initial sample and then the validation samples. So you can see it's 124 patients in the first data set, and then just like 30, 40 in the other ones. So that's why I'm saying, like, it's not a huge number of patients, but it's good for you to know this in case they're like, well, how many patients did they do this on? Or, which patients did they do it in? You don't have to volunteer this information if they don't ask you, but I always find it's better if you know more than them in these settings, so that if they ask you something, you look like the expert.
But Megan, is it done during the procedure? Is it? Because the heart rate and saturation get altered at that time?
So no, it's not like you would do it immediately for the procedure. This would be more like, do you think the baby like post-op is having pain? and like following the pain after, I don't know, they've had PDA ligation or surgery for
I'm just thinking they do it for heel lands, and there are studies which looked at pain for different things. So I was just
yeah.
wondering, so the saturation falls during NG tube or OG tube, orogastric tube placement. Is that what we are measuring?
You would, yeah, you would. But so the way they did this study is that they first had to be like, what are actually the things that indicate pain in babies? Like, this was an early study. This is, I think, late 1990s that they did this study. So there was no actual kind of established things that you should measure. So they used these videos of these different procedures and observations of the procedures to establish like the validity of the items that were in the scale. So they showed that like when babies had a heel lance, their pain response was the nasolabial fold, the brow bulge, the eye squinting, and changes in heart rate and saturation. So that's a bit why. That's why they use these events.
Yeah.
I think if you look in my slides, there's more notes in the bottom.
Yeah.
Yeah, so this was determining the factors, developing indicators, establishing internal consistency, basically. So yeah, that's why. But I wouldn't use it now. You wouldn't use it just to like score someone while they're having a heel lance or something very short, because for a short procedure, they have pain. You're going to just address that right before the procedure and give them some procedural pain management.
So Megan, what I was thinking was maybe so the DM neonatology PGs, so the super specialist PGs, they're doing
Yeah,
these quality improvement projects,
yeah.
like the one we did with sorry, 1 second. I think we have a nurse of the Nilofer project joining. And Sandhya, can you hear us? I think she's still trying to figure out Zoom.
Okay.
Um, anyway, so I was just thinking when you started speaking, maybe we should take the procedural pain management as a quality improvement project so that we get some baseline. I mean, not the whole neonatology because there are 300 to 400 babies at any given point of time. Maybe we just start with level 3, where
Yeah.
there are around 13 babies, and we look at the baseline number of procedures done, maybe.
Yeah, start with
And
something super simple, like exactly that. Like, how many painful procedures do they have on average per day?
yeah. And as interventions, as you have said, creating awareness, giving material, having a written guidelines, so that we at least sensitize them about procedural pain.
Yeah.
Uh, yeah,
That's a really good QI project. You could do like, you could do a survey like of the healthcare providers at baseline, being like, what, asking some knowledge and skills about assessment of pain in babies, and then you could do training and awareness, and then reassess knowledge, skills, and attitudes.
yeah, yeah. I don't know, Megan. I'm just thinking. I need a lot of people on my side to make it happen. So
Yeah.
yeah,
Okay, so I would put the NIPS in the same category as the PIPS scale, in that it's really nice and easy, and sort of has similar development in terms of like internal validity and consistency of the items. But I would say the weakness with the NIPS is that it wasn't really assessing premature infants. So the PIPS, because it's the premature infant pain profile, the gestational ages are lower for some of those patients who were in the study, the validation study. But for the NIPS, really, they didn't have many premature babies. I'm not going to go into detail of these other scales. They're also good. They're just, they're just different. They just look at some different items. This one, the DAN, the douleur aiguë du nouveau-né, it again is more term infants. I looked at the babies that they did the initial studies on. This one's also good. Cries. I was happy with it. I looked at its development, again, just for term infants only.
Megan, we have
NPAS,
lot of term babies in the NICUs, unlike West, because
yeah,
most of them are botched deliveries like breech
yeah,
and footling presentations who go for normal delivery, vaginal delivery, and there won't be cry after birth, and they end up in the ICUs. So unlike the West, we have lot of term 3 cages, 3.5 cages ending up with ET tubes and bagging. So.
yeah. So in that case, then maybe your best bet is to pick something like cries, because it's really easy to scale, right? Like it's, are they crying? What's their oxygen need? What's their heart rate? What's their expression? And what's their sleeping? Like, and it's like, it's a bit easier to score. Like if, maybe your initial QI target is like improve analgesia for term infants because it's an easier thing to start with, right?
Yeah, yeah, Megan, yeah.
Because preterm, if it's not their like same level of expertise, they're less comfortable, they're going to be hesitant because they're like, oh, they're premature, we don't want to, risk anything. So term babies would be a good place to start. So that's a thought. And then NPAS. So NPAS is a good scoring. It's more like kind of assessing the level of sedation. So we use these kind of scales when we have intubated patients often, and we want to decide how sedated we want the patient to be. Sometimes you want an intubated patient to be like really deeply sedated. Most of the time you want them lightly sedated. So these kind of scales help you kind of determine that. But after looking at all the scales, I think, really pick what you think would work best for your people, and then just train them up on one. There's another one. There's a lot of them. So I think that's the scales. But again, I did upload all the scales to the Google Doc folder for you. And also, I think some of the articles that back up the scales. If you go with a certain scale and you need more articles so that you, as the expert, have the background knowledge, then let me know. I'll find you all the like validation studies for each, for whatever particular one you do. So I'll touch very briefly on non-pharmacological, given that this is kind of being done and you don't feel like it's the focus. So the one thing is breastfeeding. So apparently the studies show that it really has to be done for 5 minutes before the procedure for the infant to get into like a calm state. And so as a result, then the procedure has slightly less pain. So it's appropriate for things like heel lance or like venipuncture, because you're not going to give morphine or fentanyl or something for those small of a procedure. So then for those small venipunctures, I would just make sure you have a nice non-pharmacological package. Kangaroo care, again. So this one, again, they say like you can't just have them on the mother for the procedure. It has to then be maintained post-procedure, 10 to 15 minutes. That's what the literature shows is effective. So again, both of these, the emphasis is you have to schedule it with the parent so that the parent is like fully engaged and can do the thing that you want them to do before, during, and after the procedure. So that may be a big challenge if they just want to go and do something and they don't have, sometimes scheduling and like working with parents is your biggest barrier because the team has their own agenda. Other strategies. So non-nutritive sucking. So that just means like giving the baby a pacifier or a soother, something in the mouth, but they're not drinking milk. They're just sucking. So this is good. It's even better if you combine it with sucrose. So that's coming up in another slide. Swaddling. So swaddling means like wrapping them up so that they feel contained. That's very good for premature infants, but there's not much evidence for term infants. But that's something we do routinely for premature infants as part of their routine care. That's why they should be, even in the incubator, they should have like a blanket around them and be wrapped so that they feel kind of tight and enclosed, because that's comforting for them. Music, that's been studied, but there's really no good evidence. And then there's this thing called multisensory stimulation. So this is for term babies. It's kind of like there was a study that implemented this package of eye contact, speaking gently, gentle massage, and giving sucrose. And that combination was more effective than sucrose alone. But that's only like 2 studies. So sucrose. So I don't know, are they using sucrose at all?
So Megan, when I said these people are interested more in pharmacological, I didn't mean they are using non-pharmacological. They kind of know about the non-pharmacological, but they are very offhanded about it. So they said something like, oh, we know breastfeeding and sucrose, but we want to go beyond that kind of thing.
Yeah.
So it's a little complicated there. And just to give you a picture, as I told you, there are around 300, 400 in the overall neonatology, but just the emergency room. At any given point of time, there are 5 to 6 parents who are actually bagging their baby. Like there's an ET tube, and the parent is responsible to hold it in place and keep bagging it because they don't have enough staff. And each incubator has a minimum of 2 to 3 babies, and I don't get to talk. So when they say talk to the parent, the first day I didn't know, and I sat and I offered the parent a chair. Me being an Indian, I did that, and the parent was horrified. He was like, "Oh my God, that's a doctor's chair. I can't sit in there." So it's that kind of atmosphere. Totally, like
Oh my God.
no place to talk. So if I have to talk to a baby who's dying in level 2, I have to pull her parents from like level 2 and take them to level 3 to talk because there is no room there.
So is it all just level 2 and level 3? Do you have any level 1 or not really?
So there are 2 floors of neonatology in the building, and level 3, yeah, there's level 3, there's level 2, there's emergency. There are step down units for both level 3 and level 2.
Okay.
And there are all these wards that we don't even go where the babies are fine.
Yeah. Like just kind of level 1. Yeah. And emerge. Okay. So are you focusing on level 3 then, or 2 and 3?
So level 3 is the place where I thought we have a lot more work as palliative care. But what I realize is level 3 are these mostly salvageable babies. But there might be babies who might need compassionate extubation over there, who have been there for a very long time. But what I feel is level 3 are those they're trying to actually salvage and try to make them better. But
Yeah.
These emergency room, the room from where they'll not even go to level 2 or level 3, are the place where a lot more babies are dying every day.
Because they
Like
don't, they kind of know that, and so they don't want to push them into the level 3. They want to.
So there are multiple things. I think that there are only so many level 3 beds they have, 12 or 13, and so many in level 2. And all of them, I think, they're maintaining this strict 1 incubator policy, 1 baby, 1 incubator policy. So they cannot ship the baby unless they are free, but they're almost always full. And so there is the case I'm presenting today. They're still in the emergency room, and it's 27 days that they, I think 21 days, 27 days that they have come to Nilofer, and they're still there in that crib. So they don't get bumped to a different level, even though it gets available.
Gotcha. Okay. Okay, that's super helpful. So sucrose, I mean, let me just give you some thoughts based on what you've described. So there's lots of trials that show that sucrose is really effective for procedural pain, for short procedures. Like, so what I would use it for is heel lance or venipuncture. That's about it. Maybe in intramuscular or subcutaneous injection, like if you're giving a vaccine, okay? So the combination of sucrose plus non-nutritive sucking, like with a pacifier, that's more effective than sucrose alone. I gave the indications. We have a little like sucrose policy. So this is what they have to have. They have to be able to suck and swallow. They have to be greater than 27 weeks and having some oral feeding. If they're less than 27 weeks, they can have trophic feeds, which is just like tiny amount, like 1 ml every 6 hours. And if they're NPO, but they're stable and they're over 27 weeks, they can have it. So if you need a little policy, we have one. Of course, there's some contraindications. They're very, very few, but like if they have, major bowel issues, necrotizing enterocolitis, or if they're intubated or really sedated, paralyzed, because they have to be able to swallow, basically, safely. There's dosing. So you can just make it if you have clean water and sugar. It's like nothing fancy. And you just put it on the tongue and then just suck it. And you should give it for 1 or 2 minutes before the procedure. And you usually, like ideally if you have it in a little syringe with no needle, and then you have somebody who's just like, you teach the parent, drip it onto their tongue as the procedure is going on. Like start 1 or 2 minutes before the procedure and then drip, drip, drips, keep giving it to them throughout the procedure. It doesn't work if you give the whole amount in one go. You have to kind of drip it. So that's the idea. But if you're like, it depends what your focus is. Like this is kind of, you have to train all your nurses, a bit of a program to get sucrose going. So it might not be your first choice to do. Because all you're going to do is be able to address like pain from venipunctures, which may not be your priority. Okay, so then for specific procedures, so you saw that, I don't know if you looked at the document that I sent, but basically for each procedure, they've gone through the evidence and said, what is the recommendation? What should you give for this procedure? So this is the kind of thing you could use for a QI project to work with the team there and modify these for a few procedures and just say, okay, what's the most painful procedure? What does the team there think is the time when they're causing pain is the most pain that they want to address? Maybe it's intubation. I don't know. And then you could start to develop an appropriate protocol for that procedure. Nurses in general, I don't know if it's like this in Hyderabad, but nurses like procedures and protocols, especially NICU nurses. They follow procedures well. So if you engage them in a process with the doctors, maybe deciding, but then you train the nurses and you make sure they like the protocol, then they just follow it. It's a secret. So then they'll just be happy. Okay, every time this procedure, I'm going to pre-medicate the patient with this medication, and it just goes. And you don't have to, once you get it going, sometimes it'll just run on its own, but you have to get it going. These are just some general points about procedures, like use all the types of modifications you can for minor procedures, like the environmental, behavioral, non-pharmacological. But then for like more painful things, make sure the patient is quiet and awake in a calm state before you start, so that you reduce the amount of pain that you generate. Because if they're already upset, then the pain is worse. And ideally, you have one staff to do the procedure and one to do the pain management. But I don't think that you're going to get that. So probably you're going to train the parent to do the pain management. So we could talk about specific procedures. So maybe I'm going to open it up now and say, what do you want to talk about? Because I want to make this part relevant for you.
So I have gone through this literature, Megan, when I was looking at procedural pain. So I do know that theory part of it, but I'm struggling with how do I make it possible. Mm-hmm. So because we are still not totally welcome there. I mean, we are welcome, but we have very limited hold over any of the things going on. So, yeah.
Do you think, like, what do you think is the place, like, do you want to go through the case? Because I haven't read the case. Maybe that'll help us. And then that can be a place to sort of really generate kind of ideas and feedback. Would that be the next step, do you think? Or
yeah, Megan, I think we can start with the case. Can you project it, because I'm joining in from my phone?
Yeah, give me 1 sec. So just pull it up. Hi, Gayatri. Welcome. Do you want to say hi to your nurse again?
Sandhya, do you want to introduce yourself? Okay, she's struggling with Zoom. She.
Hello. I'm really glad you could join, Sandhya.
Oh, yes. Got Megan, have you seen her? No, I don't think.
I'm not hearing you very well, Gayatri. Sorry, I can't quite follow what you're saying. Your connection's a bit unstable. So, am I sharing? Yeah. Okay, so we've just done a bit of theory on neonatal pain, and we've actually recorded it, so we'll put it up on YouTube. But Spandana is going to share a case, and I think then we're going to have some more discussion, hopefully, after the case. Go ahead, Spandana. You can just tell me next slide.
Yeah, next slide, please, Megan.
Okay.
So this is one thing I was thinking about because the baby I'm sharing about is 48 a day old and has been in hospital all his life. So could there be a risk that this baby is in chronic pain? But if we wait for the definition of 90-day thing, so that is one thing I'm thinking about. And the other point is, what is the starting place and starting point for us, because we are not from the hospital. So how do we start with procedural pain sensitization and interventions was one thing I was thinking.
Okay.
Next slide, please. So this baby is a 48-day male baby, and he's a fourth born of mother who is 33 years old. And because of anhydramnios, the mother underwent emergency cesarean section. The baby is 33-week preterm, and they suspect the baby has Downs. And as you can see, I have like a huge other diagnosis. So the suspected congenital pneumonia, DIC, persistent thrombocytopenia, and I don't know if it's actually a colloidon baby, but the skin is extremely dry, like some ichthyosis, at least the upper part of the body. So this is happening with this baby. Next slide, please. So as I've said, emergency LSCS, and the baby cried immediately after birth. There is no hypoxic ischemic encephalopathy. Very low birth weight. Baby weighed 1.5 kgs. Next slide, please. So this delivery happened at a different hospital, a private hospital. And after the birth, they suspected congenital pneumonia and put the baby on bubble CPAP. And the next line, I don't know how it worked, but the mother says, and even the case sheet recorded that in the next 5 days, the baby was put on ventilator support 5 times. Like the baby was intubated 5 different times in view of pulmonary and GI hemorrhage. So, and the baby, in that private hospital, the baby received antibiotics, antifungals, IVIG. At some point, I think they were suspecting some immunodeficiency. But then I don't know if it would make such a big difference in such a tiny baby. And they have given GMCF, granulocyte monocyte colony stimulating factor. But the baby reports show that the baby had leukocytosis. The baby received albumin, blood products. The baby was finally extubated on 27th of July. The baby's date of birth is 7th of July. And after 20 days, the baby was extubated and sent to Nilofur, saying that nothing more can be done at that particular hospital. Next slide, please. So when we assessed the baby, we saw that, as I told, the general condition of the baby doesn't look very well. The child is tachypneic and is clearly in respiratory distress. The baby has tachypnea, and intercostal and subcostal retractions are present. Even suprasternal retractions are present. And the baby is on oxygen, and on oxygen with the nasal prongs, the saturation is maintained. But I think the oxygen prongs for such a long time, the baby, it's not humidified air. There is bleeding in the nose. Mother said that today when we were speaking to her. So that is happening with the baby. And abdomen is distended. Baby has pedal edema. And ascitic fluid was clearly there. And in the past 7 days, 6 times ascitic tap was done. So that is the other thing that's happening with the baby because of NEC, necrotizing enterocolitis, and ascites. So the pediatric surgery team is being called, and they are doing the ascitic tap. And every time after ascitic tap, baby becomes a bit comfortable, and it's the same. It keeps repeating. So that is happening. Next slide, please, Megan. Sorry. Psychosocial concerns. She has 3 children, the eldest being 6 and youngest 2 years old, and they're being taken care by the family. She has good family support. Husband is supporting her, uh, but husband can't be here because it's such a long-term admission. Uh, when we were doing the counseling, because she's referred the second time to us. She was referred some 15 days ago, 2 weeks ago, by a senior consultant, and that time referral was for communication only. So they referred because the mother is very difficult to talk to, is what they have said. And the second time we got the referral after 2 weeks because the baby has clearly deteriorated in that time. So this time it was for supportive care, palliative care. So this time we took the mother into the room, we made her sit, we had the whole conversation. That's when I realized that after a long conversation, mother has shared that they have actually tried to terminate the pregnancy because they already had 3 kids. But it did not happen because once the doctor wasn't there, so she thinks that it was God's wish that she has this baby. And I think that's, she also has guilt because she has planned the termination and she didn't go through with it. And she keeps saying that whenever I give her whenever I try to talk about supportive care and palliative care, she keeps saying just because he's weak, I can't leave him. No matter how many times I try, it's not leaving him. You are never going to leave him, kind of thing. She still goes back to I cannot leave him thing. Next slide, please. She has a very strong faith, and that is what the actual treating pediatricians are finding it very difficult to talk to, because after hearing everything, she says, even after you say very clearly, it looks like he is going to die, she says, if God created life, he will show a solution. There must be some medicine. I'm hoping for a miracle. And my intuition says he will survive. So that is the note she ends every conversation with. So the doctors are finding very difficult about that. Next slide, please. So our conversation, at the end of it, I think we made a little progress because she said, I understand what you're saying and I'm not ready to accept. So she made it very clear. I don't know if I'm ready to accept. I don't think I'm ready to accept. And she went back to the same thing, saying that I believe my child will survive. So Sandhya and I responded that we too hope that the child survives. But have you thought about what happens if that is not the path the baby is going to go on? So we had that kind of conversation, and I think she wasn't offended at the end of it. So next slide, please. So yeah, this I have already said. They have approached us before. So one question I had was, by the time we saw the baby earlier and even today, the baby is about 1 month, but the baby is still under neonatology because of all these problems. So what do we use? Do we use just the term scale, NIPS or NPAS, or do we have to use flag scale because the baby is more than 1 month old? So that is one thing I was wondering about. And how do we make this child comfortable? So there are two approaches. One thing is we wait for them to say completely, you take care of them. The other thing is we work in collaboration with them, and we try to make him as comfortable as possible at Nilofer. But then there are all these barriers where I cannot encourage the mother to hold the baby much because that is not the protocol of the hospital. So I don't know how else can we make this child better, not better, at least comfortable was one thing I was thinking. And pharmacological management of pain in neonates. I've written morphine, but I'm not sure we can use morphine in any of these children because Morphine is not I don't think you can access morphine of Nilofers. They don't have morphine. They do have fentanyl that is for mostly for post-op babies. They use it, but so that is one more thing. And what can we start with? Where do we start? What is the starting point?
Those are great questions. Really good case. Like it just lots of things. Can I just ask a few clarifying questions about the case?
Go ahead, Megan.
So right now the baby's just on oxygen, not on intubation or CPAP or anything.
Yeah, the baby is just on oxygen.
Okay. And did they diagnose lung hypoplasia? Because that's my suspicion given the story they tell.
No, Megan, there is no mention of lung hypoplasia.
Because if there was a baby that had no fluid, right, the
Yes.
lungs don't develop. So I would suspect that that's why the baby's still on oxygen, partially, maybe other things too. Is there any congenital heart disease? Have they checked to make sure there isn't?
I know that they wanted to go, but I did not find any report. And because they're suspecting Down syndrome, I'm sure they'll get a cardiac consultation at some point.
Yeah, because I just wonder, another reason, why is this baby still on oxygen? Why does he have such bad ascites? You know, like.
I think the ascites is because of necrotizing enterocolitis, but yeah, this late presentation, I'm just thinking about it.
But neck, like is the baby still on antibiotics for neck? Is the baby being fed? Like, neck doesn't just go on and on and on. Doesn't typically.
Yeah. The baby has been receiving antifungals, colistin injections, so all the antibiotics, but I don't know. They stopped feeding, but there's an OGT for medications.
It doesn't fit totally with neck. That's why I'm like, maybe there's more things going on than just plain neck.
Yeah.
But it's not for you to decide. It's just a bit like, kind of helps us understand what's going on. Very interesting about the GCSF. Totally crazy and not indicated. But there's a thing that babies with Down syndrome get. Like it's not a congenital leukemia. It's called but it's sort of like a mild congenital leukemia. And whether he had any kind of variation on that early on with the hyperleukocytosis. I'd have
and the thrombocytopenia too. So the father wants to talk to me about bone marrow transplantation. So that is one more conversation I should have with them. Yeah. Mother is very well read, unlike a lot of patients who, families who come to Nilofer. She converses in English most of the time. So they do all these internet research, and now they want to talk about bone marrow transplantation. Yeah.
Oh, it's definitely not indicated.
Yeah.
Transient myeloproliferative disorder is a condition that is basically only seen in newborn babies with Down syndrome, where they have just like this transient myeloproliferation. And sometimes we just give them like a tiny bit of chemo and it just kind of goes away. And sometimes you just wait. But I think that's more for you to know. But it sounds like that's probably mostly resolved unless there's still like really high white counts and stuff. The thrombocytopenia might just be like baby's really sick kind of thing. So let's talk about your questions now. I think that's like, given that we said I have only 10 minutes and then I'd have to go, unfortunately. So what pain scales do we use for children above 1 month in NICU? So the evidence is you can use either. You can use FLAC or you could use NPAS or NIPS.
Okay.
They would some of the NIPS data was on babies over 1 month of age, and we continue to use NIPS. If the baby's in NICU, they just use NIPS. So
okay.
You just, if that's easiest, just stick with the NIPS, because a lot of the features on the NIPS are totally acceptable, or on the NPAS they're fine for over 1 month old, especially because this baby's not term yet, right? Like he's just getting to term corrected. So definitely if they're still preterm, like say the baby was 27 weeks, now 1 month old, they'd only be like 32 weeks corrected, then you would continue to use it at least until they're 45 weeks, 48 weeks, corrected. I'm going to go to this third question because it's easy, and then we'll come back to the second. Pharmacological management of pain in neonates. So I agree with you about fentanyl. It's probably not going to be feasible for you to get access to fentanyl and give a lot of fentanyl because it's very short acting in general. And you're going to want something like either ideally oral that you could give that would give like some sustained pain relief, right? That's kind of your thought, is that this patient is like kind of having probably persistent pain. Even if it doesn't meet that definition of chronic pain, it meets the definition of persistent pain, like as per the WHO guidelines. And for persistent pain, then you could you were not wrong to go straight to the WHO ladder and just address it via the WHO ladder. So step one would be like, you could, a child this age, as long as the liver's okay, you could just give paracetamol oral as a starting point to at least know that you're doing something to make the child more comfortable. That would be my first thought. And then second, like, it's useful to have access to oral morphine, oral and IV, like for your purposes, like not just for this case, you probably need both. That's a very tricky question. How are we going to manage that for you? You can also use methadone. Like if you could find a way to get methadone, if you like, it's not common to prescribe it in babies, but if it was like easier to access and, because they didn't know about it, they would let you do it. I wouldn't say it's wrong to do methadone. Or if you have any other opioid that you have access to, like some of the ones that are not so common, like buprenorphine, or I don't know, what's the other one that you guys sometimes, they had a TATA memorial that we thought was kind of weird.
That's tapentadol, and I don't think tramadol or tapentadol we can use in neonates now.
Okay, but so tell me more about that based on what I've said. What are your thoughts?
About morphine, Megan? Sorry, Megan, I didn't get your question.
So does it sound okay to use NPAS or NIPS for pain scale? Do you think that would be okay?
Yeah, I think that would be okay. So I was also thinking, because if we are going to start talking about procedural pain, we also have to receive questions from that end. So that was something I think we will get definitely asked about. So yeah, I think that's a good answer.
So,
and then for pharmacological.
Megan, can you hear me?
Not very well.
Hello?
You're really choppy still, Gayatri. Spandana, can you hear Gayatri okay?
No,
Okay.
That's better.
Okay, let me try.
Or type
so my
your
question is, we have to differentiate between the acute procedural pain. Oh yeah.
Dr. Gayatri, I'm unable to hear you. I think I kind of made we have to differentiate between acute procedural pain and, but there was lag between your words. It's difficult to understand.
Can you hear me? Hello?
Sort of. It's on and off. A bit. We can hear you a bit.
Like what I want to say is, when you're having some procedure is being done, I don't think FLAC will be so useful. That's the point of time. I think it's mostly by observational thing we have to go. And FLAC will be more kind of persistent pain. I think it'll be useful. That's what.
Yeah, I agree. Yeah, we talked about that earlier. We went through some of the pain scales. For short procedures, like you're just doing ascites tap or heel lance, like, you're just going to prep that child by initiating some pain relieving things, non-pharmacological plus or minus pharmacological, and you're not going to score them just during the procedure. You're going to like think that you're going to just kind of look at them and be like, okay, he looks like he's pretty comfortable, because it's not you're busy doing other things during the procedure. Someone's doing the procedure, right? But I think the scales, like the NIPS and the FLAC, will be useful for you in situations where you think this baby is having persistent pain. like this ascites is like persistently bothering the baby. They're having, I don't know, they have some other reason to have persisting pain. They've had surgery. They've, they have an injury, or, whatever it is. Like a baby with HIE can have a lot of neuro irritability after the birth depression. So for those ones, then that's when you want to get the nurses scoring so that you can prove the patient has pain, and you can prove that if you give them regular paracetamol, morphine, whatever, that then the pain scores are lower consistently. So you want like 2 or 3 pain scores a day, and then you want those scores to go down with your interventions if you're going to treat them on a around the clock basis. Does that make sense?
Yeah, absolutely. Suppose a baby has a cannula and which is not really working well, and if you try to inject a medicine through that, if it is painful, so what we will observe is suddenly the heart rate going up, and that's a very diagnostic that something is not all right. It's painful when they're pushing medicine and its heart rate is going up. So it's very indicative of probably baby is having pain. So that's why observational, we have to look at more about the observation, how the baby reacts to any procedure. So that's something I want Sandhya and Spandana also to remember when you're looking at procedural pain and trying to assess pain. We have to go more by observation than by these scales in acute pain.
Yeah, the scales, some of the scales have incorporate heart rate as a part of the scale.
Yeah, part of it. It's not like by itself, I think. Yeah.
Heart rate, oxygen saturation, blood pressure, if you have access to it. And then
the monitors. So we can see that actually. They're on monitors. It's they're on all sort of monitoring. So we can make out.
Okay. I think in the interest of time, I'm really sorry. Today I have to go to a meeting right at 11, some administration thing. So can we just touch on the pharmacological piece and any comments on that? The second bullet point is very important. I think we save it and we kind of have a discussion more about that in our next echo. So paracetamol regularly is totally safe and fine for a 1-month-old as long as they're not like in liver failure. Morphine, methadone, what are your thoughts? Buprenorphine?
No, I think Spandana have to make some morphine available. It's not difficult. We can get it available, and we have to use morphine because not with these kind of babies, but I've seen a 2-week-old baby with this kind of some kind of congenital born with some leukemic problems, leukemic disorders, and they fail to suck, and the only way and we never know it's painful if the baby is in pain or not. But when we gave morphine, they woke up kind of. They started sucking, and the overall their health improved. They put on weight, so we could see the dramatic response in relation to cancers. I would still strongly recommend that we should be very actively looking for such pain. Yeah. And
I mean, maybe oral morphine is a good place to start too.
Yes. Yeah.
The youngest we have prescribed I have prescribed morphine to is a 9-day-old with congenital leukemia. But then again, cancer, it's kind of easy to make them understand about pain and the rest. But when it comes to non-cancer, which is almost all the children in Nilofer, it becomes a little difficult, challenging.
I think we have to start with some really painful babies, really, where it's very obvious. You try and then show them the response. They're not seen it yet. They're never seen being used. So that's something we have to understand. Yeah.
I agree. And I also agree, like you showing some of these guidelines that we use and just saying like, this is standard now. Like this is not questionable from the literature anymore. This is really like, we have established that these, anything that needs an opioid, these procedures, we do need to give morphine. Like I know we're suggesting fentanyl because we have lots of access to fentanyl for procedures. But, oral morphine, and we can talk about dosing, not today, we don't have time, but we could just focus on like, how do you dose morphine safely in a premature infant or in a term infant? Because it's doable and it's very good. And like this baby, my guess is this baby has some pain, right? This baby has probably some dyspnea, sounds like, because they have lung hypoplasia. plus or minus other things going on. And then this abdomen is probably very uncomfortable if there's ongoing necrotizing enterocolitis or if there's ongoing kind of distension from ascites. And sometimes, like Gayatri's saying, the nice thing you see is that the heart rate comes down really nicely, because the heart rate was sometimes up by 20 or 30 beats just for pain. And then you can show. But I think that's where the scales come in, because they're going to argue with you, but you say, look, I'm going to score the baby. We're going to give a trial of morphine and we're going to see, and we're going to rescore. And, you wait till the baby's calm when you score them at baseline, and calm after you've given the morphine to kind of, ideally get kind of parallel measurements. But that's when I use the scales, because we have the same issue here that the neonatologists are like, oh, the baby's fine, he's not in pain. And I think the baby's in pain, and the nurses think the baby's in pain, because usually the nurses and I are really at the bedside and seeing the patient more. And then we use the scales plus a trial of opioid to show that the patient's having pain. Anything that would be considered painful in adults is painful in babies. I don't know if that will help you convince them, but, those are my thoughts. I'm going to have to sign off here for today. It's a really interesting discussion. Spandana, I'm really glad you brought this case. It's really interesting. So I would propose that we do our next session next week. And because this is really kind of giving me a really good insight into what you guys are facing and struggling with, and hopefully giving you some points to think about. And I think this will help us when I come to Hyderabad in a month to really kind of have some, this will generate some ideas for things we can work on before and also while I'm there.
Yeah.
Does that sound okay?
Yeah. Thank you, Megan.
Yeah, Megan, thank you.
Any final thoughts, Spandana? I'll just give you a minute to sum up as,
I think Ishak has been really using a lot of morphine in the hospice, both adult and children. So he's quite used to it now. Ishak?
Ma'am, actually, I had a small doubt regarding use of morphine in preterm babies. I got into one study where I saw was the routine use of morphine infusion was particularly not recommended in ventilated preterm neonates. So I just wanted a slight clarification on that.
I would go with the WHO guidelines.
Okay. Okay.
Not just one study, and you can show me that study, but let's look at guidelines that are a summary of a lot of studies together.
Okay. Okay. Yes, ma'am.
No issue. Definitely, we use opioids in preterm babies. There shouldn't be any issues. I mean, we have to make sure they don't stop breathing, because they do that a lot.
Yes,
but that's a dosing issue and a monitoring.
When you're talking about ventilation, and they're worried about they prefer short-acting opioids. When you're talking about maintaining ventilation.
Yeah.
So here we're discussing chronic pain.
Yeah.
Okay.
Yeah, definitely. If you give a baby an opioid, and it's they need lower doses and longer dosing intervals.
Okay.
But if they're ventilated,
okay, ma'am. Okay.
It's a ventilator for that problem. But there's no issue. I give methadone to premature babies, clonidine, everything. So, but that we can talk about more, because today was just focused a little bit procedural pain. So I'm going to sign off now, and we'll meet at the same time next week. And next week I have a full hour and a half, so we can spend a bit more time on the discussion. I think next week, Ishak, it'll be your turn to do the case.
Yes,
so please bring a case.
Yes,
and maybe we'll do, what was the topic, Spandana, you had said for the next neonatal echo?
I think it's neonatal sedation.
Do you want to do that one, or do you want to do one more on pain treatment and just look at the research?
Let's.
Ma'am, I don't know regarding that. I have to go through the topics. So,
Guys, what did you say? Do you want to do pain treatment?
Yeah, I think continue on pain.
Okay, let's do one more on pain. We can always add on the sedation after that. So
yes. Okay,
yeah.
ma'am.
Perfect. Okay, I'll see you guys next week then.
Thank you, ma'am.
Bye.
Okay.
Bye, Megan. Have a good day.